Hello, I'm Mark Sigman from Brown University. In this video I'm going to analyze the data comparing the results of IVF and ICSI between sperm retrieved from the testicle and from the ejaculate in couples with elevated sperm DNA fragmentation and prior failed IVF or ICSI cycles. The concept of utilizing testicular sperm for couples with high sperm DNA fragmentation, also called SDF, that have failed prior IVF or ICSI cycles relies on several assumptions. As we will discuss, these assumptions are either inaccurate or unproven. The main assumptions are that SDF testing is a good assay, that IVF or ICSI failed because the sperm had elevated sperm DNA fragmentation, and that testicular sperm will yield better results than ejaculated sperm. This management concept assumes that SDF testing is a good diagnostic test for predicting pregnancy. Clinical assays are evaluated by standard parameters of sensitivity, specificity, and by ROC curves. ROC curves plot both sensitivity and specificity. Good diagnostic tests will plot a curved line bending towards the upper left corner of the graph, and you can see that in the upper left graph in the slide. In contrast, poor tests, or worthless tests, no better than flipping a coin, will have a straight 45-degree line, as in the bottom left graph. As can be seen by the graphs of the four most common SDF assays, the testing characteristics are very poor as tests to predict pregnancy by ART. The assays have not been validated in clearly defined populations, while the protocols and definition of elevated SDF are not standardized and vary from lab to lab. The second assumption of this debate is that testicular sperm is of better quality than ejaculated sperm. When examining sperm quality, we find a mixed bag of results. Some reports have found lower SDF scores in testicular sperm than in ejaculated sperm. However, there is also more sperm aneuploidy in testicular sperm than ejaculated sperm. This raises questions about the safety of this approach. The third assumption is that testicular sperm will result in higher pregnancy rates than ejaculated sperm. As this recent meta-analysis demonstrates, in men with rare sperm in the semen, an improvement in pregnancy rates was not shown with the use of testicular sperm. There have been several reports of using testicular sperm for couples with elevated SDF scores. Unfortunately, the study designs greatly limit the ability to draw conclusions about this approach. Most studies are case series reporting results of IVF-ICSI cycles in couples with elevated SDF and failed prior ART cycles. The problem with this study design is that it compares failed prior cycles to subsequent cycles in the same couples. As can be seen in this graph, prior failed cycles do not predict failure in subsequent cycles with ejaculated sperm. In fact, pregnancy rates are quite good with just repeating ART cycles without changing the source of sperm. Therefore, pregnancies that occurred after using testicular sperm may have also occurred if the cycles were repeated with ejaculated sperm. There have been only 2 cohort studies that used control groups. One did not report live birth rates, while the other did not enroll couples that failed prior ART cycles. As of yet, there have been no randomized controlled trials, leaving us with very poor quality evidence supporting this approach. Further complicating the interpretation of published studies is the variability in types of male factor patients enrolled and the definition of elevated fragmentation. Some reports were of couples with severe oligospermia, others of only moderate oligospermia, others with only normal spermia, while others had a mixed population of patients. The value of SDF considered elevated varied from 7% to 15% to 30% in different studies, indicating that patients may have been considered normal at some institutions while others would have classified them as having elevated SDF. At this point in time, the practice of testicular sperm retrieval for couples with failed IVF-ICSI and elevated sperm DNA fragmentation should be considered experimental. The existing data supporting this approach is of low quality. Sperm DNA fragmentation assays need validation, refinement, and standardization. And importantly, the risks of testicular sperm retrieval for both the patient and progeny should not be ignored. Thank you.